Hello everyone and welcome to our second video on renal physiology. All the items listed on this slide are measurements that are obtained to determine how well the kidneys are functioning, and we're going to talk about how all of these measurements are obtained for a given patient's kidneys. So the first measurement is the most important. That's the glomerular filtration rate. This is how much liquid passes through the filter, i.e. the glomeruli of the kidneys. So we want to measure the total flow rate of fluid going through all the glomeruli in the kidneys. Second measurement is the renal plasma flow. This is how much liquid the kidneys handle. So in other words, how much liquid goes into all of the glomeruli in the kidneys. We can also measure the filtration fraction. This is of all substance X entering the kidney, what percent gets filtered, and we'll talk more about that in a minute. And then finally, we'll talk about renal clearance, which is a measurement of how much of each blood component gets removed, and it's calculated in an unusual manner, so we'll talk more about that in this video. On this slide is a drawing that I'll refer back to throughout this video. So this is a glomeruli, and what we've got is the renal plasma flow is the blood flowing into the glomeruli, and the renal plasma flow represents the sum of the flow into all the glomeruli in the kidneys. The GFR is the glomerular filtration rate, and this represents the sum of the flows of all the fluid going across all the glomeruli in both kidneys. And then finally, we have the urine flow, which is the amount of fluid flowing out of the kidneys after it has been filtered by all the nephrons in the kidneys. This can be easier to understand if we put some actual numbers in. So let's imagine that the renal plasma flow is 5 liters per minute. This is the total volume flow of fluid into all the glomeruli in both kidneys. Let's further imagine that of that 5 liters per minute, 2 liters per minute crosses the glomeruli and enters the nephrons. Then the GFR would be 2 liters per minute. And we could also calculate a filtration fraction for the kidneys. The volume that is being filtered is 2 liters out of a total 5 liters coming in, and that gives us a filtration fraction of 40% for both kidneys. We could also calculate some numbers for a specific solute in the plasma. So for example, if we go back to our measurement of GFR of 2 liters per minute, let's suppose that that GFR is made up of 2 grams per liter of sodium. We could then calculate what's known as the filtered load of sodium. This is how much sodium is passing through the glomeruli and entering into the nephron. That filtered load would be 2 liters per minute, the GFR, that's the total volume of blood flow crossing the glomeruli, times the concentration of sodium, or 4 grams per minute of sodium is being filtered, and that's called the filtered load for sodium. And finally, if we know the urine flow rate, we can determine the urinary excretion of a given solute. So for example, if we know that the kidneys were producing 100 cc's per hour of urine and that the concentration of potassium within that urine was 10 milliequivalents per cc, we could then calculate the body's excretion rate of potassium. It would be 100 cc's per hour times 10 milliequivalents per cc, or 1,000 milliequivalents per hour. So I went through all that to help you understand some of the commonly measured variables that we use to assess renal function. And what we're going to do in the next few slides is talk about how we can use some easily obtainable values to get some important measurements of kidney function like renal plasma flow and GFR. So what we're going to try to do is take plasma concentration of certain substances like sodium and glucose, the urine concentration of those substances, and the urine flow rate, and use these to determine the renal plasma flow and glomerular filtration rate. These things are all relatively easy to obtain. We can take a blood sample and measure the plasma concentration of solutes. We can take a urine sample and measure the urine concentration of solutes. And if we ask the patient to collect their urine over 24 hours, we can then determine the urine flow rate in liters per minute. So from these 3 easily obtainable or relatively easily obtainable measurements, we will try to get some important measurements of what's going on in the kidneys like renal plasma flow and GFR. Before we can talk about how to calculate renal plasma flow and GFR, I need to talk about renal clearance. This is a number that is determined for a substance or solute in the blood like sodium or glucose, and it represents the volume of blood cleared of a substance of X. Or another way to look at this is the volume of blood that contained the amount of X that was excreted. To understand this, let's imagine that we have 1 liter of blood inside a container. This container has 1 liter of blood, and within that blood there are 5 grams of sodium. Now let's imagine that the kidneys excrete 5 grams of sodium per hour. Well, it's very easy to imagine that the kidneys are getting rid of 5 grams of sodium per hour. What's harder to imagine is the concept of renal clearance. That 5 grams of sodium was originally contained in 1 liter of blood or plasma. Therefore, the clearance of sodium is 1 liter per hour. What we mean by this is that 1 liter of blood is being completely cleared of sodium per hour because each liter contains 5 grams and we're removing 5 grams per hour. And that's what the concept of renal clearance of a substance or solute means. Renal clearance is reported in liters per minute or volume flow, and it can be determined by the equation shown on the screen. The clearance of substance X is equal to the urinary concentration of substance X times the volume flow rate divided by the plasma concentration of substance X. So what this means is, if we know the plasma concentration of a solute and the urinary concentration, and we also know the volume flow of urine, we can then calculate the clearance of any given solute. One of the most important applications of the concept of renal clearance is in determining the glomerular filtration rate. The GFR is a very powerful measurement that tells us how healthy the kidneys are. As the kidneys begin to fail, the GFR begins to fall. So we want to know what the GFR is for a given patient to determine how healthy their kidneys are. And we can measure the GFR by measuring the clearance of certain substances. The first substance I'll talk about is inulin. Inulin clearance can be used to measure the GFR. Inulin is not naturally occurring and not naturally found in the body. It's a saccharide substance with the chemical structure shown on the screen, and you can administer it to a patient and determine the clearance of inulin to experimentally measure the GFR. The reason inulin clearance can be used to measure GFR is because inulin is neither secreted nor resorbed by the nephron, so any inulin that is filtered at the glomerulus goes out. To make this clear, let's imagine that we have a glomerulus and we've got a certain amount of inulin coming in and a certain amount of inulin getting filtered at the glomerulus. All of this inulin is going to go out in the urine. None of it will be reabsorbed by the nephron, and furthermore, the nephron will not secrete any inulin. So everything that crosses the glomerulus goes out, and that makes the clearance of inulin a measurement of the glomerular filtration rate. So the amount of blood cleared of inulin is the amount or volume of blood filtered by the glomerulus, and therefore the clearance of inulin in liters per minute is equal to the GFR. And as I showed you before, the equation for clearance is on the screen here. The clearance of inulin is the urinary concentration of inulin times the urine volume flow divided by the plasma inulin concentration. And we can measure all these variables in an experiment after we administer inulin to a patient, and then we can determine that patient's GFR. In clinical practice, we never use inulin clearance to determine GFR. Inulin clearance is only used as part of physiology experiments. In clinical practice, what we use to estimate a given patient's GFR is the creatinine. Creatinine is a breakdown product of muscle metabolism, and it is the closest naturally occurring substance to inulin. As I told you before, for inulin, all filtered inulin goes out with no secretion or reabsorption. For creatinine, all filtered creatinine goes out and there is a very small amount of secretion, but this amount is tiny and negligible, and therefore we often use creatinine instead of inulin. Now when you do this, the secreted creatinine will be counted as filtered, and this will very slightly overestimate the GFR, but as I said before, this is a relatively trivial overestimation, and therefore creatinine can be used to measure the GFR. So one way to measure the clearance of creatinine and use that as an estimate of GFR would be to use this equation at the top of the screen here. If you wanted to do this, every time you wanted to know a patient's GFR, you would have to measure the plasma concentration of creatinine, get a urine sample and measure the urine concentration of creatinine, and also ask the patient to hold on to their urine for 24 hours so that you could determine the volume flow of urine. This is very cumbersome and it's almost never done in clinical practice. Instead, what we use is special formulas that convert creatinine to GFR based on variables that are specific to the patient. There are a number of these that are used clinically. One's called the Cockhoff-Gralt. This is shown at the bottom of the screen. It estimates the creatinine clearance based on the patient's age, weight, and whether or not they are female, and the plasma creatinine concentration. So to use this, all you need to know is the patient's age, weight, and gender, and you need a single blood sample to measure the creatinine. You don't need to do all this stuff up here to get the volume flow rate of urine. There are also some other formulas that are sometimes used. One's called the MDRD, and there are many others. Let's talk in a little bit more detail about the relationship between the plasma concentration of creatinine and the GFR. Shown on the screen is the equation for creatinine clearance, which, as I told you before, is essentially equal to the GFR. The numerator of this equation is the urinary creatinine concentration times the volume flow rate of urine. This is the amount of creatinine that goes out per unit time in the urine, and that's equal to the amount produced. Whatever amount is produced on a daily basis by breakdown of muscle mass must be excreted on a daily basis. What this means is that this top part of the equation is essentially constant over time because your muscle mass is constant, you're producing a constant amount of creatinine every day, and therefore you're excreting a constant amount of creatinine over a day. So really, this equation can be changed to look something like this. And you can see from this equation that we've got a constant in the numerator, so anytime the plasma creatinine value goes up, the creatinine clearance will go down, and therefore that reflects a fall in the GFR. So for example, if you double the creatinine from 1 to 2, you would half the GFR. And if you plot this on a graph, you get something like what's shown on this slide here. You can find a graph like this in many physiology textbooks. As the GFR goes up, in other words, as the kidneys are filtering more fluid, the creatinine in the plasma goes down. The opposite is also true, that when the kidneys become sick and the GFR begins to fall, you will see a rise in the serum creatinine. So sort of a general principle of renal medicine and clinical medicine is that in worsening renal function and a fall in GFR, you see a higher blood level of creatinine. And I've written some sample values here on the screen. So patients with normal kidney function usually have a creatinine that is less than about 1.0 or 1.1. For example, 0.8 would be a normal value. Patients with chronic kidney disease can have a higher creatinine like 2.0. These patients have sick kidneys, but their kidneys are still functioning and they haven't progressed to the point where they have end-stage renal disease. Patients with end-stage renal disease who require dialysis can have very high creatinines as high as 4 and sometimes even 5 or 6. For step 1 of your boards and also for clinical practice, you should be aware that the GFR declines with age. Elderly patients like this woman shown on the screen here have a lower GFR than younger patients. This is not always accompanied by a rise in the serum creatinine level. Remember that creatinine is produced by muscle mass, and many patients lose muscle mass with aging, and therefore the serum creatinine may stay normal even though the GFR is declining. So using formulas like the one on the bottom of the screen is very important because they take age into account when estimating creatinine clearance in addition to the serum creatinine level. And this is very important clinically because some medications require adjustment based on the GFR, so you need to take the patient's age into account. So back to our schematic of the various measurements of renal function. So we just talked about how you can determine the GFR using inulin or creatinine. Now let's talk about how we could determine the renal plasma flow. In other words, how much fluid is flowing into all the glomeruli in both kidneys. To determine the GFR, we used inulin or creatinine. To determine the renal plasma flow, we use a substance called para-aminohippuric acid, or PAH. Its chemical structure is shown on the screen here. PAH is not naturally occurring in the body, but it can be administered as part of a physiology experiment, and then we can use the clearance of PAH to determine the renal plasma flow. The reason that PAH is useful for measuring the renal plasma flow is because it is filtered and secreted such that 100% of the PAH that enters the kidneys leaves blood in the urine. This means that the clearance of PAH in liters per minute is going to be equal to the plasma flow to the kidneys in liters per minute. To make this more clear, let's imagine that we have a glomerulus and we have coming into that glomerulus some PAH in the plasma. Some of that PAH will be filtered and will enter the tubules of the nephron, but some of the PAH will not be filtered. But whatever PAH is not filtered will then be secreted by the nephron, and it will also enter the tubules. The net result is that 100% of this PAH that comes into the kidneys will end up going out in the urine, and therefore if you can determine the clearance of PAH, you will be measuring the renal plasma flow. This is different than for inulin or creatinine. Those substances were filtered, but some of them were not filtered, and those that were not filtered were returned to the body. In the case of PAH, this does not happen. Instead, any PAH that is not filtered ends up getting secreted into the urine. So in a physiology experiment, we can measure the plasma concentration of PAH, the urine concentration, and the urine volume flow rate and determine the clearance of PAH, and this will be equal to the renal plasma flow. Now just an aside here, PAH clearance slightly underestimates true renal plasma flow by about 10%. This is because not all of the plasma and blood that goes to the kidneys goes to the glomeruli. Some go to other non-glomerular structures. So sometimes this is called the effective renal plasma flow, and the true renal plasma flow is slightly higher. Let me talk briefly about the difference between plasma and blood. So blood is plasma plus cells and protein. If you centrifuge blood, you will get something like what's shown on the screen here. About 55% of blood is plasma. There's a tiny bit that is made up of leukocytes and platelets, and then about 45% is erythrocytes. For this reason, the renal blood flow is greater than the renal plasma flow, and there are separate calculations to convert a renal plasma flow, like we determined with PAH, into a renal blood flow that includes the flow of the red blood cells. The way that renal blood flow is determined from renal plasma flow is by using the hematocrit. Blood, as I told you on the last slide, is plasma plus cells and proteins, and the percentage of blood that is cells and proteins is roughly equal to the hematocrit. And the hematocrit is an easily obtainable number in clinical practice. So the math works out such that the renal plasma flow is renal blood flow times 1 minus hematocrit. So for example, if we knew that renal blood flow were 10 cc's a minute, and we knew that 40% of that blood was cells and proteins, that's the hematocrit, that means 60% of the renal blood flow must be plasma. Therefore, the renal plasma flow is the 10 cc's a minute times 1 minus 0.4 or 0.6, which works out to 6 cc's a minute. Another way we can rearrange this equation is to say that the renal blood flow is equal to the renal plasma flow divided by 1 minus the hematocrit. So for example, if we knew the renal plasma flow from an experiment using para-aminohippuric acid, and we also knew the hematocrit, we could then calculate the renal blood flow. An example of this calculation is shown on this slide. If we knew the renal plasma flow were 1 liter a minute and the hematocrit was 40%, then the renal blood flow is 1 over 1 minus the hematocrit, or 1 over 0.6, which is 1.6 liters per minute. And on your exams, you're sometimes asked to calculate not just the renal plasma flow, but the renal blood flow, so you have to know how to do this using the hematocrit. So back to our slide, just to summarize everything we've talked about. We talked about how you can measure the GFR, which is the fluid that crosses the glomeruli, by using either inulin or creatinine and determining the clearance for those substances. We talked about how you can determine the renal plasma flow, which is the fluid flowing into all the glomeruli, by using the clearance of PAH. And we've also talked about how you can measure the urine flow, the fluid out of the kidneys, experimentally by asking a patient to collect their urine over 24 hours. And just to continue our review of everything we've talked about, the filtration fraction is how much plasma to the kidneys gets filtered. It's equal to the GFR over the renal plasma flow. Normal is about 20%. We also talked about the filtered load for a given substance. This is how much of a substance gets filtered. It's equal to the plasma concentration times the GFR, and this is the amount of substance X delivered to the proximal tubule by crossing through the glomerulus. So basically what we've done is taken these measured variables like urine flow, plasma concentration, and urine concentration, and used them to determine some other more helpful variables in establishing how healthy the kidneys are. These are variables like clearance and plasma flow and GFR and filtration fraction. And then once again, inulin clearance or creatinine is used to measure GFR, and PAH clearance is used to measure renal plasma flow. Let's talk about the effects of prostaglandins and NSAIDs on renal physiology variables. Prostaglandins are signaling molecules synthesized by many cells in the body, and in the kidneys, prostaglandins are used to dilate the afferent arteriole and increase the renal plasma flow. NSAIDs are non-steroidal anti-inflammatory drugs like ibuprofen, and they block the production of prostaglandins. In the kidneys, this will lead to afferent arterial vasoconstriction. So what's going to happen is there's going to be less plasma flowing into the kidneys, so the renal plasma flow will fall. Because less plasma goes into the kidneys, there will be less filtered at the glomeruli, and the GFR will fall. The filtration fraction, like I told you earlier, is equal to the GFR divided by the renal plasma flow. And because both of these variables decrease in the setting of NSAIDs, you will see no change in the filtration fraction. And they'd like you to know these effects for your boards. Clinically, in patients who are healthy, this has no important consequences. However, in patients with chronic kidney or heart disease, this can lead to acute renal failure or retention of sodium in water and acute heart failure. And for that reason, NSAIDs are avoided in patients with heart failure and renal failure. ACE inhibitors also have important effects on renal physiology. ACE inhibitors are drugs used in hypertension and heart failure, and they block the synthesis of angiotensin II. And angiotensin II's normal role is to constrict most blood vessels in the body, but in particular, angiotensin II preferentially constricts the efferent arteriole. So if you give an ACE inhibitor, you will dilate the efferent arteriole. So what will happen here? Well, let's imagine that we have a glomerulus. This is the efferent arteriole over here. If we dilate this afferent arteriole because we administer an ACE inhibitor, blood is going to rush out of the glomeruli. This is going to increase the renal plasma flow, but because we have more blood exiting the glomeruli, less will be filtered into the nephrons and the GFR will fall. This means that the filtration fraction is going to fall because remember, the filtration fraction is the GFR as the numerator, the renal plasma flow as the denominator, and since the denominator is going up and the numerator is going down, we see a fall in the filtration fraction. They like you to know these effects for step 1 of your boards. Now let's talk about secretion and absorption. There are 3 factors that determine how much of a solute is excreted in the urine. The first is how much is filtered at the glomerulus. Obviously, if you filter more of a solute like sodium, then potentially more will go out in the urine. The second factor that determines excretion is the secretion rate. So some solutes are secreted by tubule cells, and this will lead to more going out in the urine. The final factor is absorption. So some solutes like sodium and potassium can be absorbed by the kidneys. So the more that is absorbed, the less will go out in the urine. So it's the sum of these effects, how much is filtered, how much is secreted, and how much is absorbed, that determine how much will go out in the urine. So for example, let's imagine that we know the GFR, which is the fluid that crosses the glomerulus, and then we calculate the filtered load of a substance. For example, let's suppose it's sodium. That will be equal to the GFR times the plasma concentration of sodium. We can then calculate the amount of sodium that goes out. If we know the urine flow, which is the fluid out of the kidney, and we know the urinary concentration of that solute, like sodium, we can determine the excretion rate. What if the filtered load doesn't equal the excretion rate? This must mean that there is some secretion or absorption that is modifying the amount of that substance going out, such that the amount going out is not the same as the amount filtered. And this is the effects of secretion and absorption by the nephron. So just to summarize, the amount of a substance excreted is equal to the amount filtered minus any that is reabsorbed plus any that is secreted. The amount filtered we can determine from the filtered load. That's the GFR times the plasma concentration. The amount excreted is the urine flow rate V times the urinary concentration. So if we take the difference between these two, that tells us how much reabsorption or secretion is going on. So for example, suppose that 10 milligrams of X per minute are filtered, but 20 milligrams of X per minute are excreted. We're excreting more than we're filtering, so an additional 10 milligrams per minute must have been excreted. So anytime the amount filtered is equal to the amount excreted, that means there's no net secretion or reabsorption. If the amount filtered is less than the amount excreted, then some must have been secreted by the nephron. If the amount filtered is more than the amount excreted, then some must have been reabsorbed. So for example, if for a particular substance 100 milligrams a minute is filtered and 120 is excreted, an additional 20 milligrams per minute must have been secreted. Example 2, suppose that 100 milligrams per minute are filtered, 80 milligrams per minute are excreted, then 20 milligrams per minute must have been reabsorbed. These are important concepts for you to understand. I'm going through them step by step to make them very clear. We can also gain some insights into secretion or absorption of a particular solute by looking at the clearance of a solute. So for example, if the clearance of solute X is equal to the GFR, then there must be no net secretion or reabsorption. And we talked earlier about how this is the case for inulin. In the case of inulin, what we have is a situation where the clearance is equal to the GFR, and that's why we use inulin to measure the GFR. If the GFR is less than the clearance, then there must be secretion of that solute. So for example, if we're filtering so much of a substance, but we're actually clearing more of that substance, then some secretion must be going on in the tubules. The opposite is also true. If the GFR is more than the clearance, then there must be some resorption. So for example, assume the GFR is 100 milliliters per minute, but the clearance of a solute is 120 milliliters per minute. Then an additional 20 milliliters per minute must be getting cleared by secretion. The converse is also true. If the GFR is 100 milliliters per minute and the clearance of X is 80 milliliters per minute, then an additional 20 milliliters per minute must be uncleared or reabsorbed by the nephron. Now let's talk about intake and output of solutes. We talked earlier about how the excretion rate of any solute is equal to the urine flow rate times the concentration of that solute X in the urine. And you should know that this excretion rate for any solute has to equal the amount that the body takes in every day. For example, you have to excrete the daily load of sodium that you take in your diet. The same is true of potassium and many other substances. The amount of any substance in must equal the amount out. Where this gets confusing, especially at the medical student level, is when an insult occurs like renal failure or diarrhea, and you're asked what happens to the excretion rate. When one of these insults occurs, there's a transient imbalance that alters plasma levels, but then steady state quickly returns, such that if you're eating 10 grams a day of salt, for example, you're still excreting 10 grams a day. And this is something you have to understand. So for example, if something happens to the kidneys that impairs their ability to excrete sodium, eventually a new steady state will return where the amount of sodium being excreted is equal to the amount coming in. If it does not, you will die. So the kidneys modify their excretion rate of solutes so that they continue to excrete what is taken in. This happens in healthy states and in disease states, and this is one of the most confusing topics in renal physiology. To drill down on this further, let's talk about how different solutes are handled by the body in the setting of renal failure. Regulated solutes include solutes like sodium and potassium. The levels of sodium and potassium are tightly controlled by the body. ADH controls sodium levels, aldosterone controls potassium levels. This means that in the setting of mild to moderate renal failure, there's no concentration change. If your body allowed sodium and potassium levels to rise in mild to moderate renal failure, you could die from volume depletion, because in that setting your GFR falls and you would get hypernatremic or hyperkalemic. But that does not happen because these solutes have regulated levels so that they stay normal as long as you still have some kidney function left. Other solutes like creatinine and urea are unregulated, and their plasma level rises in the setting of renal failure. So for example, in a patient with hemorrhage who has a fall in GFR, that patient's creatinine and urea level will rise because these solutes are not regulated by the body. To make this more clear, let's build a table together, and let's start by considering a patient who has a normal GFR of 100. That patient will have values for potassium, sodium, and urea in the plasma that are normal as shown on the table. Now let's imagine that patient develops some type of insult and the GFR falls by half to a level of 50. Well, that patient will still have a normal plasma level of potassium and sodium because these are regulated solutes and the body does not allow them to rise in the setting of a fall in GFR. Urea, however, is unregulated, so its level will rise in the plasma when the GFR falls. This has consequences in terms of the filtered load. Remember, the filtered load is the GFR times the plasma concentration. So the filtered load for potassium and sodium is going to fall. That's because there's less GFR and the plasma concentration has not changed. However, the filtered load for urea is exactly the same. The GFR fell by half and the urea level doubled. In other words, the only way the kidneys can eliminate urea is through filtration, so they must maintain the filtered load. Potassium and sodium, the kidneys can secrete these substances or reabsorb less, therefore the filtered load is allowed to fall and the kidneys will manipulate the amount of secretion or reabsorption. Here's the tricky part though. The daily excretion rate of potassium, sodium, and urea is always the same. It has to equal the intake. You must excrete all the potassium and sodium in your diet, and you must excrete the urea produced by metabolism. So even though the GFR has fallen by half, the excretion rate has not changed. And that's a very tricky concept. Make sure you understand that. And what about the fractional excretion? The fractional excretion is the excretion rate divided by the filtered load. The excretion rate has not changed and the filtered load has fallen for potassium and sodium. Therefore, the fractional excretion has gone up. In other words, the kidneys are excreting much more of what they filter because they are filtering less. In the case of urea, there's been no change in excretion rate, no change in filter load, so the fractional excretion has not changed. Make sure you go through this carefully and understand everything on this slide. It's very high yield. I'll finish this video by going through a couple sample renal physiology problems of the type you're likely to see on your board exams. A patient has a urine output of 4,800 cc's per day or 200 cc's per hour. Plasma concentration of substance X is 4 milligrams per deciliter. Urine concentration of X is 8 milligrams per deciliter. What is the clearance of substance X? So this is a basic problem where you're simply asked to use the clearance equation and plug these values in. So they tell us that the urine concentration of X is 8. They tell us that the volume of urine flow is 200 an hour. And they tell us the plasma concentration is 4. So if we plug all these numbers in, the clearance for substance X is 400 cc's per hour. Question 2, a patient is infused with inulin. At steady state, plasma concentration of inulin is 3 and urine concentration is 6. If the GFR is 200, what is the urine flow rate? So we have to remember that GFR is equal to the clearance of inulin. That means that we already know the clearance of inulin. What they want us to figure out is V, the volume flow rate of urine. So we just plug in the numbers here. We solve for V. It's equal to GFR times the plasma inulin concentration divided by the urinary inulin concentration. If we plug in the numbers, that's 200 times 3 over 6. Therefore, the volume flow rate of urine must be 100 milliliters per hour. Question 3, a patient is infused with PAH. At steady state, plasma concentration is 5 and urine concentration is 10. If the urine flow rate is 200 milliliters per hour and the hematocrit is 50, what is the renal blood flow? So there's a lot of numbers here, but if we just use the basic equations we talked about in this video, this problem is very easy to solve. So the clearance of PAH is equal to the clearance equation, which is equal to the renal plasma flow. We also know that renal blood flow is renal plasma flow over 1 minus hematocrit. So if we rearrange this, we can now say that the renal plasma flow is equal to the urine concentration, which is 10, times the urine flow rate of 200 divided by the plasma concentration of 5, or 400. Once we have the renal plasma flow, we then use the hematocrit to convert that to a renal blood flow. That's equal to 400 over 1 minus 0.5, or 800 milliliters per hour. Note that the numbers in this problem are relatively easy to solve. You don't really even need a calculator, and that's typical of what you're likely to see on your board exams. Question 4, a lab animal has an inulin clearance of 100 cc's per hour. So right away you should recognize that they are telling us the GFR by giving us the inulin clearance. Plasma concentration of substance X is 4 milligrams per milliliter. It is known that substance X is not reabsorbed but is secreted at a rate of 25 milligrams per hour. What is the excretion rate of substance X? So to solve this problem, we have to remember that the amount of anything that is excreted is equal to the filtered amount minus reabsorbed plus secreted. They have given us the secreted amount at 25 milligrams per hour, and they have told us that nothing is reabsorbed. So all we need to do is figure out the filtered load of this substance, and then we will know how much is excreted. The filtered load of any substance is the GFR times the plasma concentration. Using the values in the problem, that's 100 times 4, or 400 milligrams per hour. Therefore, our excretion rate is the 400 milligrams per hour that was filtered plus the 25 secreted, or 425 milligrams per hour. So a lot of numbers here, but this is very straightforward to solve. And once again, this problem shows a general point, which is the amount of anything that is excreted is equal to the amount filtered minus the amount reabsorbed plus the amount secreted. This comes up again and again in renal physiology. I'll leave you with a couple of key points. Anytime they tell you the inulin clearance, they are giving you the GFR, and the GFR can be used to calculate the filtered load of other substances as long as you have the plasma concentration of that substance. The amount filtered of any substance is the filtered load, that's the GFR times the plasma concentration. The amount excreted of any substance is the volume flow rate of urine V times the urinary concentration of that substance. And then excreted is filtered plus secreted minus reabsorbed. And remember that for inulin, whatever is filtered is excreted because there is no net secretion or reabsorption. And that concludes our second video on renal physiology.